Good morning, everyone. Today, for the next 20 to 25 minutes, I would like to share my experience and the learning lessons which I have learned through the antimicrobial stewardship with you. Uh, Generally, in majority of the talks, what I have heard is the strategy for antimicrobial stewardship and roles and responsibility of every individual. But however, I felt a very important component of this antimicrobial stewardship is the knowledge related to treatment aspect of the individual, that is choosing the right antibiotic. I feel that is most important critical component of this antimicrobial stewardship. In a scale of 100, I will place this as more than 80 or 90% because choosing the right antibiotic is the most critical factor in the antimicrobial stewardship. So, for choosing the right antibiotic, appropriate antibiotic, what are all the nuances of translating susceptibility report to effective therapy? I'm going to discuss today with you all. Disclaimer. So, antimicrobial stewardship, you all know, it's the, I usually say it as a 6D. The first D is drug, appropriate drug. That's very important. As I told you, if the drug is not appropriate, then rest of the components doesn't add value. So appropriate drug, its dose, its dosing interval, and for how long you are going to give, then it needs to be de-escalated. And along with this antibiotic therapy, parallelly, if required, debridement has to be done or drainage, means essentially controlling of the source is very important. Then only the drug will act. So this is the important aspect of the antimicrobial stewardship. Another D, I given it in the blue, which means the microbial diagnosis. If you don't know what organism is infecting, then it's very difficult for you to choose the right drug. So it's very important for you in the first place to know what bug is infected and what is the MIC of the bug. If it is resistant, what is the resistant mechanism of the bug? So once you know this information, then you have almost 99% you have achieved. All you need to do is give the targeted therapy. As I told you, it's not that simple. Only in 10 to 15% of the patient care you can achieve this. In majority of the time, you may not know the organism. Even if you know the organism, you don't get the accurate MIC. You may not get the resistant mechanism. So it's very important to improve your lab diagnosis and the information you require for an appropriate therapy prescription. You need to have an effective microbiology lab. So that's why it's very important. Antimicrobial stewardship success largely depends upon diagnostic stewardship. So what is diagnostic stewardship? It's right test, right patient at the right time to inform optimal antimicrobial use. That is what diagnostic stewardship. So it's very important for a good antimicrobial stewardship, you need to have a diagnostic stewardship. When both are there, then this will result in best clinical outcome as you desired. It will be there. It will give a very minimal toxicity, minimal resistance selection of the ecology or your hospital environment. So the overall, not only for the individual patient, even for the community, it's well and good. So with this in the mind, I am structured my talk. So, how to achieve appropriate therapy through diagnostic stewardship. So, it's usually once you do the blood culture, then we will wait for the blood culture to flag positive. Now there are a lot of techniques are there to identify the organism much earlier, but it's evolving, and we don't have a good sensitivity specificity uh, methodologies to pick up organisms straight from the blood culture. So once it flags positive, from there it's possible to identify the organism. So either the overnight subculture, the colony, or even without colony, the moment it flags positive from the blood culture supernatant, you can achieve identification of the organism through molecular method, and even the susceptibility molecular method as well as phenotypic method from the blood culture supernatant you can achieve. So that is the fastest way you can pick up the organism ID and the AST, and you can go for an appropriate therapy. So it's very important in this multi-drug resistant era to go for an early diagnosis. So not only the rapid test is alone is good enough, the rapid test should be coupled with antimicrobial stewardship. So here in the first forest plot, you can see the rapid diagnostic test, molecular rapid diagnostic test without antimicrobial stewardship is of no benefit. Can you? So no change in mortality, time to effective therapy, and the length of stay. There is no change was observed if there is only molecular rapid diagnostic test without ASP, that is antimicrobial stewardship. Whereas with molecular rapid diagnostic test, if the results are available in the midnight and if that can be communicated to the physician and physician immediately executes its change modification of the antibiotic dose duration, something like that intervenes, or it translates the antibiogram into effective implementation, then significant decrease in mortality, decreased the time to effectiveness of the therapy, and length of stay is found. So it's very important. 24 into 7, the laboratory generates the data, and as well as once the data is available, that is implemented to the patient 24 into 7. Then only you can achieve good result. So there are many number of kits are available in the market. You can see in this table. Uh, First two are directly from the blood sample, but it is not fully available and throughout the world, and very few centers are doing, and it's quite cumbersome. Reliability is less. You can see that in the sensitivity specificity. It may take time, whereas the T2 bacteria panel seems to be good. So far, so good, directly from the blood sample. Remaining all successful platforms are directly from the blood. It's not possible. Only from the positive blood culture supernatant it is possible. But the remaining all the platforms you can see as an excellent sensitivity and specificity with the shortest turnaround time of 1 to 5 hours. So now, if there is an affordability and accessibility to the platforms, definitely you can achieve early identification and AST, and eventually right therapy can be started at the earliest with reduced morbidity mortality. So now in this slide, I am showing you the difference between the phenotypic and genotypic. In the phenotypic, the growth will be there, whereas in genotypic, growth won't be there. So you may not have a minimum inhibitory concentration, rather you will have absence or presence of the resistant gene. When you have the resistant gene, then you can predict resistant, but you can't say whether it is susceptible or not. Whereas with the phenotypic test, you have the minimum inhibitory concentration. You are equipped to say whether it is susceptible, intermediate, or resistant. That's possible. So, whereas in genotypic, that is not possible. And here it can be quantifiable, quantitative as well as qualitative. Here it's not quantifiable. And validation is much easier with the phenotypic. Validation with the genotypic is little tricky. And with the experience, we will learn and we try to interpret. So that is the difference between the phenotypic and the AST. But it is now mandatory that both genotypic for the earlier diagnosis and the initiation of the appropriate therapy that needs to be confirmed subsequently with the phenotypic test. So now, in addition to the phenotypic, the routine standard of care is genotypic also. And I would like to tell the how well these two are correlating. This is a nice slide, and I would like to draw your attention for Meckier, Vanier. You can see the approximate accuracy is close to 100, and for both the presence of the gene and absence of the gene is quite good. When it comes to gram negative for ESBL, CTXM, or for carbapenemase, that 5 big carba, you can see the presence approximate accuracy is fantastic. When it is absent, that is not the true. You can see this is one between ranges widely between 50 to 95. Again, for carbapenemase also, if the gene is absent, the reliability is 50 to 95%. So if it is present, gene is present, then it's much more safer, 95 to 100%. That what I mean to say is presence of the gene is for resistance, it's accurate. Whereas for susceptibility, it's not the so. So this is one of the important lesson you need to understand. And what is currently available in the developed nation is accelerator phenosystem, where identification of the organism and susceptibility of the organism by phenotypic test, which is possible within 5 to 7 hours. Both are ready. Whereas other than this system, rest of the things takes time. Very recently, the FDA has approved a antimicrobial susceptibility platform called Reveal Specific, which determines the susceptibility based on the volatile compounds present in the metabolic end as a metabolic end product of the susceptibility, where it will give you the minimum inhibitory concentration, especially in the gram-negative pathogens. So these are all the two advanced system which gives you accurate result with the shortest turnaround time. But at present, these are quite expensive. And other other platform for early identification of the resistant mechanism is the expert CARBA, and the 5 big carbapenemase enzymes are easily picked up by the expert CARBA. And BioFire, in addition to identification of the organism and antimicrobial susceptibility, and it can detect the resistant mechanism also. That is by the BioFire. So these are all the advanced tools available in the microbiology laboratory. So this is a complex world of beta lactamase. Every individual who prescribes antibiotic should know what is the mode of action of the antibiotic, where it can work, where it can't work. Because to effectively interpret the lab report, you need to have an understanding of this knowledge. Here I would like to show you that avibactam will act only when OXA48 is there, whereas none of the other beta lactamase inhibitor can inhibit OXA48. Only avibactam can do that one. And similarly, for metallobeta lactamase, if it is there, this enzyme can be hydrolyzed only by the monobactam, not by any other beta lactamase inhibitor or antibiotic. So this is the profile of each antibiotic and the enzymes which it can act on. So this is one important information which by heart all the prescribers should know. Okay. So you will get a report like this of the 5 big carbapenemases, what is positive. Then by knowing the earlier tabular column by heart, you will know that if OXA48 is positive, the best drug to treat is ceftazidime avibactam. Whereas you may not get the susceptibility of amikacin and ciprofloxacin in the molecular susceptibility. Whereas when you do subsequently standard phenotypic susceptibility, at that time you will know about the other antibiotics in addition to confirming the molecular susceptibility, that is ceftazidime avibactam, you have confirmed. And now you have the MIC. And if there are any other change or additional information will be obtained from the standard susceptibility testing. So this is the way you have to go. You will get the answer and this is how you have to interpret, and this needs to be confirmed like this. So as I mentioned to you earlier, both the laboratory and the ID physician has to continuously work around the clock to bring in a significant change in the patient's outcome. So now the standard of care has become 24 into 7, especially already it's there in the critical ill patients, even in the patient in the ward. If you really want to have an effective therapy and the earlier discharge, then this needs to be implemented. So there are two things needs to be carried out from the microbiology lab, that is selective and cascade reporting. What is selective reporting? So one example I can give, first I will tell what is selective and cascade reporting, then I will give it with the suitable examples. Selective reporting is based on the organism, from which site you have collected or isolated the organism, what is the clinical setting and what is the resistant mechanism. Based on this information, you will do the selective reporting. Cascade reporting is if one narrow spectrum antibiotic is susceptible, it's better to withhold the broad spectrum antibiotic. So that unnecessary misuse or overuse of antibiotic doesn't happen. So now I will give it an example. So selective reporting, here I am giving you Acinetobacter baumannii with the resistant mechanism of OXA23. If it is in the bacteremia, we will choose instead of actually carbapenem and polymyxin are contraindicated recently. This is a old slide. I would have preferred to give minocycline with sulbactam in this situation. In pneumonia also, we used to prefer minocycline with the sulbactam. Whereas for intra-abdominal infection, we wish to go for an tigecycline with or without meropenem. Osteomyelitis, minocycline with or without meropenem. If it is pyelonephritis, we choose amikacin or colistin. If it is CNS, again we will go for sulbactam-based therapy. So it all depends based on the organism from different sites, based on the PK/PD parameter of that antibiotic, the best will be given. So this is called as selective reporting. Next, I move on to explain the cascade reporting. Here you can see if third generation cephalosporin or beta-lactamase inhibitor is susceptible, there is no need to give carbapenem result. Please withhold the carbapenem result. If the beta-lactamase inhibitor and third generation cephalosporin is resistant, then you are mandated to share the carbapenem result. If carbapenem is resistant, then only you can give the colistin susceptibility. Otherwise, there is no need to give the colistin susceptibility. In case even colistin is resistant, then you can give the susceptibility for tigecycline or the combination synergy test of various combination you can report. So this is the algorithm which everyone needs to be followed, and this is mandated by the antimicrobial stewardship guideline recommendation. So now I move on to certain tips to share from the gram-negative pathogens. So whenever you are prescribing any antibiotic for E. coli infection, say bacteremia, you have a lot of choice. You have a carbapenem sparing agent, you have a colistin sparing agent, you have the novel drugs. When, how to choose, it's very important to have to choose the right antibiotic. You need to know the resistant mechanism of E. coli and how the given antibiotic works for that resistant mechanism. In E. coli, you can see the dark green colors are susceptible, yellow is may or may not, and the light colors are resistant. So this profile is totally different from the next slide for Klebsiella. In the Klebsiella, you can see the resistant mechanism is not that many number like E. coli you see here, and the combinations also very minimal. The choices are more. So it is what the one drug which is which is good enough for E. coli always may not be good enough for Klebsiella. It all largely depends upon the resistant mechanism, and the resistant mechanism may vary from region to region, country to country, continent to continent. So you need to know what is the common resistant mechanism, what is the MIC, and how you can manage with as a monotherapy or combination therapy, what is suitable for your locality. So it's very essential to know your local data. That's why they say that think globally and act locally. So your local data is very, very important. No international guidelines which is not appropriate for your setting is of no use. There is no point in blindly following international guidelines for every corner of the globe, because one size doesn't fit all. So now piptazole may not be very effective in most of the situations in India and in Southeast Asia. So instead of choosing that as a first line drug, you can go for an cephalosporin sulbactam. This is one example I am giving. So you need to know what should be the first line and second line based on your baseline resistant mechanism of common isolates, clinical isolates. So if it is an AMP-C producer, you can choose a monotherapy with the cefepime provided the MIC is less than 2. If it is more than 2, it's better to avoid cefepime. Rather, it's better to go for a carbapenem, that is meropenem. And similarly, if AMP-C producers are known, then definitely it's better to avoid the second generation cephalosporin third generation cephalosporin, and beta-lactam inhibitor like piptazole. And sometimes in Klebsiella, etramimpenem will be resistant, imipenem, meropenem will be susceptible. That is due to the porin deficiency. That can happen. In that situation, this is mostly seen in Klebsiella. This is due to outer membrane protein loss. In that case, we can choose meropenem. Similarly, for Proteus providentia and morgagni, meropenem will be highly susceptible, whereas imipenem MIC will be very high. So it's better to avoid imipenem in this organisms. And it's better in most of the pneumonia or lower respiratory infections, as the guideline insists on avoiding colistin, that should be strictly followed. And similarly, tigecycline should be, or any tetracycline group should be avoided for urinary tract infection. And this is another important lesson which you should keep in mind. How the inoculum effect will derail your appropriate therapy, where the dosage and durations are very important, and your lab test also need to be very careful. So I just want to explain you the ESBL E. coli. If the standard inoculism is 10 to the power of 5, it will have a susceptibility of 79%. If the inoculum increases to 10 to the power of 7, you can see the susceptibility coming down to 21. And another best example, all this you can see how the cefotaxime, ceftazidime, cefepime, piptazole falls. What is 79 and 95 here are 5 and 16. So only meropenem can overcome this inoculum effect. So what is this inoculum effect translates to the clinical picture is infective endocarditis is an eye inoculum infection, and pneumonia, lower respiratory pneumonia is an eye inoculum infection. Then bone and joint infection, and obviously any abscesses is an eye inoculum infection. These are all the places where the basic knowledge of this understanding is very important. And nowadays, they do ceftazidime, avibactam, and aztreonam testing for multi-drug resistant organisms, especially New Delhi metallo-beta-lactamase. In that situation, what happens is the best methodology to follow is test strips. The sensitivity specificity are very high by strip cross method or strip stacking method. These two are my recommendations, and it can be followed alternate to the broth microdilution. Whereas there are many number of literatures are there. Please look for the sensitivity and specificity. And in many things, they may even claim 100% synergy, but methodology may be at flaw, interpretation may be at flaw. So you need to know which one to follow. My recommendation is best to go for broth microdilution, if not the E-strip cross method or E-test strip stacking method. Apart from these three methods, we don't want to recommend anything else. So when you are doing aztreonam synergy can be demonstrated for any drop in fourfold reduction in the MIC. So synergy, if it falls from 128 to 2 grams, then it is synergy, 4 or 5-fold. And it will be susceptible if the aztreonam is less than 4, because the breakpoint for aztreonam is 4. Here we are using avibactam to protect the aztreonam, so that aztreonam should work on the metallo-beta-lactamase. So the cutoff should be less than 4. That should be the breakpoint here we need to follow. Here, just the drop in the MIC should not be our endpoint. So this is synergy and susceptible, the second row. Third row, there is a synergy drop from 128 to 16 is there, but it has not gone beyond 4. So synergy is there, but it's not susceptible. So this is very important for all of you to understand. So now I move on to the non-fermenting gram-negative organism. So you need to have a better understanding of this. It's a little complicated, but the microbiology lab can help to guide you for Pseudomonas aeruginosa therapy. I don't want to get into the details. All I would like to simplify and say is, in majority of the country, Pseudomonas resistant is due to porin loss or efflux overexpression and inducible AMPC. So these three are the most common resistant mechanism you notice. But in our country and certain countries, in addition to this, you have New Delhi metallo-beta-lactamase. It's more like a multiple resistant mechanism is playing. Hence, your choice for antibiotic is slightly complicated. So make sure that any Pseudomonas aeruginosa, if it is resistant to carbapenem, you need to know it's whether it's due to porine efflux or inducible amphicy in addition to NDM. So these three are the most common. NDM will be or may not be there. So that you have to identify, then accordingly treat. So other tips which I would like to share is tetracycline group should not be used for Pseudomonas aeruginosa. If imipenem is resistant, it means porine loss. If meropenem is resistant, imipenem is susceptible, it's due to efflux. And generally, cephalosporins are better than carbapenem for Pseudomonas aeruginosa. And for Acinetobacter baumannii, uh, usually it's recommended to avoid colistin carbapenem combination. Minocycline sulbactam works very well, or uh, any colistin combination seems to work well other than carbapenem. Colistin sulbactam or meropenem sulbactam are the best recommendations as of now. Eravacycline will be much better once it's available everywhere as a combination therapy. So nowadays, many people are using carbapenem upfront. Hence, carbapenem intrinsically resistant organisms like Stenotrophomonas maltophilia, Elizabeth kingae, Chrysobacterium, Purpureria, Cenocepacia, Achromobacter, and alkaligens. Either it will be an intrinsic or acquired carbapenem resistant organisms are very frequently encountered in the clinical situation. For this, the best first line drug we recommend or widely the data available is the trimethoprim sulfamethoxazole IV. That's what I try to say in this slide. Now I move on to the last couple of slides of gram-positive pathogens. For staph aureus, vancomycin susceptibility is quite good, and you can try that one because almost 90%, but only PKPD is the problem. Achieving the right drug, sustainable drug, and clearing of the organisms may take time. For that, you may require therapeutic drug monitoring. Irrespective of all these things, even though if it is less than 2 and susceptible clinically, if they are not responding, so just ignore the MIC value and choose an alternative therapy. Just dump vancomycin, go for other things. When you use more of an vancomycin, be reminded that it may choose vancomycin resistant enterococcus selection will be very high in that hospital. And when it comes to enterococcus, you know that you generally the cephalosporin, clindamycin, and cotrimoxazole are not recommended. And when you take the interpretation for ampicillin, that applies for all other narrow penicillins and beta-lactam, beta-lactamase inhibitor. And when you're treating for with the daptomycin, the less than 4 milligram per liter susceptible, dose dependent needs to be considered. So usually it ranges from 8 to 12 milligram per kg body weight. And here also cephalosporin inoculum effect is there. If it is less than 8, it will be the standard inoculum criteria. If it is I inoculum more than 16, then it's may not be very effective. So for pneumococci, if penicillin is susceptible, it's well and good. If there is a low level resistance, that can be picked up by comparing the penicillin MIC and the cefotaxime MIC. If cefotaxime is less than 1 and penicillin is more than 0.006, then still you can continue only with the monotherapy with the third generation cephalosporin. If along with penicillin, cephalosporin MIC is more than 1, then it's always advisable to add vancomycin to the third generation cephalosporin for invasive meningeal streptococcus infection, but not for non-meningeal infections. The cephalosporin alone is good enough to treat for all other non-invasive meningeal infections. So finally, I would like to wrap up with the take-home message. So the most important thing what I would like to re-emphasize is determine the identification of the causative infecting agent with its susceptibility profile as early as possible using molecular test directly from the blood culture supernatant. That's more important. Once you have the susceptibility and identification, just look for the MIC and mechanism of resistance. And with that knowledge, you can choose the appropriate therapy. When you have chosen the appropriate therapy, the dosage and dosing interval can be arrived based on the PKPD target it can achieve. And in case if this cannot be achieved, then go for a combination therapy in critically ill individual. And always, not only antibiotic therapy alone is good enough in many situations. You need to have a debridement or reversal of immunosuppression is very important. So with that, I would like to conclude my nuances of translating susceptibility data into prescription. Thank you. Thank you very much.